Hi again. Let's talk about GI perforation. So the most common cause of GI perforation is necrotizing enterocolitis. However, it can occur in the absence of NEC as well, and that's spontaneous intestinal perforation. Signs of an intestinal perforation include abdominal distension, respiratory distress, deteriorating blood gases, decreasing blood pressure, and pneumoperitoneum, also known as free air on the X-ray. The absence of free air does not rule out perforation. Prematurity is a major risk factor for spontaneous intestinal perforations. The simultaneous use of NSAIDs and steroids, for example, indomethacin and hydrocortisone, also have been associated with GI perforation. So it's important that you know that. GI perforations can also occur due to trauma, such as nasogastric or orotube placement, vigorous positive pressure ventilation. And if you ever see an NG tube that's in an unusual position on the X-ray, that indicates that there could be a perforation there. For example, I remember taking care of a patient and seeing on the X-ray the NG tube just went straight down instead of curving into the stomach like you'd normally see, and that baby had a perforation. So just be mindful of those types of things and always look at the X-ray. Even if you're not totally sure what you're looking at, over time you will learn. Infants with bowel obstructions, for example, meconium ileus, that are being treated with water-soluble enemas are also at risk for intestinal perforation, and that risk will increase with multiple attempts of relieving the meconium. There's different factors we might see that will help us distinguish a focal perforation from something like necrotizing enterocolitis. And in necrotizing enterocolitis, they are really hemodynamically unstable. They have metabolic acidosis. They don't do as well compared to if there's just a focal spontaneous perforation, then we see less hemodynamic instability and less metabolic acidosis and an improved survival rate. Treatment of a GI perforation will really depend on the cause of the perforation. The pediatric surgeons will be consulted to help determine next steps, and babies will be cared for with general supportive measures, which include starting IV fluids, making the baby NPO, and gastric decompression. Surgical intervention typically includes an exploratory laparotomy with bowel resection, and then non-surgical interventions can also be considered in a selective number of babies who don't have peritonitis and there's not surgical indication. So now let's talk about necrotizing enterocolitis. And I think this is one of those diseases, these pathologies that really freaks all of us out. None of us want to see necrotizing enterocolitis. So let's talk about what is NEC. So it's an intestinal disease that primarily affects premature and medically fragile babies. It's caused by an inflammatory process that leads to intestinal tissue damage. The underlying cause is not well understood, and perinatal stressors, an immature intestinal barrier, intestinal ischemia, bacterial colonization of the gut, and alterations of the intestinal microbiome, which is dysbiosis, and then what we're feeding the gut, all have been identified as contributing factors that play into the causes of NEC. We try and prevent NEC so that we don't see it in our patients, of course, and some of the interventions that we have taken on to prevent it include a human milk diet, standardized feeding protocols. Many places have started using probiotics. We want to avoid prolonged antibiotic use and avoid H2 blockers. Something interesting that I have learned is that NICUs that have a standardized feeding protocol have lower NEC. And so it doesn't necessarily mean that the standardized feeding protocol has to be a certain thing, like increasing by 10 mLs per kilo per day or increasing by 20 mLs per kilo per day or fortifying to 22 and then 24 versus fortifying just to 24. All of those don't matter as much. What they've found that matters is that the NICU has a standardized protocol and everybody is following the same patterns. So I thought that was super interesting when it comes to preventing NEC. But let's talk more about the pathophysiology of NEC. So as I mentioned, it's a multifactorial process that initiates intestinal mucosal damage and the inflammatory cascade. Inflammation and ischemia initially involve the inner lining of the intestinal mucosa, but as the disease progresses, the other layers of the bowel become involved. And then we start to see intramural gas or pneumatosis. And if you see a cross section of those bowels, there's all these little bubbles in the intralumen of the bowel, and that's that gas that's it's being created by the bacteria. So when you're caring for a patient, what might you see? So a lot of the signs can be quite nonspecific. So your baby may have feeding intolerance, abdominal distension. Bloody stools is not very nonspecific, but there can be different causes of bloody stools. Of course, we are concerned about NEC. As the disease progresses, the baby will develop signs and symptoms of septic shock. So you'll see that the baby will be lethargic, there will be increased respiratory distress, temp instability, hypotension, and oliguria. Infants that are most at risk include our preterm babies, particularly when they're at 30 to 32 weeks corrected gestational age, babies with gut dysbiosis, so babies born by C-section, if they've been exposed to antibiotics for long courses or multiple courses, and exposure to H2 blockers. Also, babies who are at risk are babies who are receiving enteral feeds, especially if they're receiving hyperosmolar formulas. And then other factors can increase that baby's risk, like maternal smoking, when they receive red blood cell transfusions, and even we think there could be a genetic disposition. So since you're concerned about your baby possibly having NEC, you would anticipate that the providers would order a septic workup. So on our septic workup, we would see thrombocytopenia, neutropenia, and metabolic acidosis. CRP levels are increasingly obtained and appear to be a good marker of the onset, persistence, and subsequent resolution of NEC. So initially our CRP may be normal, and that's because it takes 6 to 8 hours after trauma, basically, or an inflammatory event for that CRP to rise. So initially our CRP may be normal, and then subsequent CRPs are done on an interval anywhere from Q12 to 24 hours. Some places may even do Q6 hours, and you might see it rise if that baby had NEC. And then our blood gases would reveal metabolic acidosis, or we might see a mixed metabolic and respiratory acidosis if that baby is really decompensating and having a lot of respiratory distress. Other diagnostic tests that we would do include the abdominal x-ray. So we may do a series where we're doing a left lateral decubitus, in some instances cross table views. So plain radiographs are carefully reviewed for characteristic findings of pneumatosis intestinalis or intramural bowel gas. The x-ray would be assessed for free air, also known as pneumoperitoneum, and that would suggest intestinal perforation. Other findings might include dilated bowel, portal venous gas, ascites, or a fixed bowel loop that doesn't change on repeated studies. We take all this information, and that's utilized to characterize NEC based on the modified Bell staging criteria. So the modified Bell staging criteria is used, like I said, to classify NEC, and that's according to clinical and radiographic presentation. So stage 1 is suspected NEC based on non-specific signs. So our temp instability, apnea, lethargy, abdominal signs like abdominal distension, gastric residuals, emesis, and bloody stools. And then on our abdominal x-ray, it might be normal, or it might show dilation of bowel loops and ileus. Stage 2 is confirmed NEC and includes the symptoms of stage 1 plus absent bowel sounds and abdominal tenderness. And then on our labs, we might see mild metabolic acidosis and thrombocytopenia. The abdominal x-ray will show pneumatosis intestinalis with or without portal venous gas. And then stage 3 is advanced NEC, and it includes findings such as severe metabolic and or respiratory acidosis, respiratory failure, hypotension, neutropenia, shock, and DIC. The baby's abdomen is tense and discolored with spreading erythema, edema, and induration, which is a sign of peritonitis. The hallmark radiologic sign, or the sign that we'd see on our x-ray, is pneumoperitoneum, which is that free air. So the baby has NEC. What are we going to do? What's the next steps? So bowel rest and preventing progression of the disease is the initial treatment for necrotizing enterocolitis. The baby is going to require TPN, 7 to 14 days of being NPO, gastric decompression, respiratory and circulatory support, and close monitoring of labs and antibiotics for 10 to 14 days. The only indication for surgical intervention is intestinal perforation or pneumoperitoneum. When the baby does need to have surgery, basically the principle or the plan for the surgeons is to resect all the necrotic bowel while preserving as much of the intestinal length as possible. After bowel resection, proximal and distal ostomies are created, and the abdomen is thoroughly irrigated to reduce bacterial and fecal contamination. Post-operatively, we would provide supportive care, so resuscitation fluids, TPN, and antibiotics, and bowel rest for 10 to 14 days. At about 2 weeks post-operatively, we can restart low osmolar enteral feeds or breast milk. That will help return motility. So we'll slowly advance feedings as that baby is tolerating. The stoma closure procedure is planned for as early as 6 to 8 weeks after initial surgery. All infants should undergo preoperative contrast enema before the ostomy closure just to make sure that the intestine and colon distal to the ostomy have not strictured, which can be a complication. So speaking of complications, NEC is a significant risk factor for developing short bowel syndrome chronically. If less than 40 centimeters of the small bowel remains in absence of the ileocecal valve, or in the presence of less than 20 centimeters of bowel, then that baby would have short bowel syndrome. Stomal prolapse or retraction, wound infection, intra-abdominal abscess, and intestinal obstruction are all early complications of NEC. Recurrent NEC is not very common, but it can occur. About 5% of babies treated medically or surgically can have recurrent NEC. But the most significant late complication is that of inadequate intestinal length or the short bowel syndrome. And for those babies, they often will need long-term parenteral nutrition. Really, when babies need surgical intervention, the preservation of the ileocecal valve is really critically important because that is what slows intestinal transit and limits the sequelae of short bowel syndrome. So babies at the highest risk of short bowel syndrome have the ileocecal valve, but less than 20 centimeters of a small intestine, or they have no ileocecal valve and they have less than 40 centimeters of small bowel. For infants that are treated medically, nearly a third of them will develop a distal intestinal stricture. Most commonly, it occurs in the colon, and it requires operative intervention to resect and restore the intestinal continuity and function. Risk of mortality for NEC is 20 to 30%, but it's higher with our lower gestational age babies and with those who require surgical intervention. Infants who have had NEC are at risk of neurodevelopmental impairment. So of course, NEC is like one of the biggest, scariest disease processes that we see in the NICU, and it's a high priority for all of us to try and prevent it.